Hey everybody, sorry for the delay. I don't know what was going on. My webinar software was not cooperating. Finally in here. All right, so welcome to BFR Tuesday. My name is Ed Cara, and I host this. Every Tuesday we talk about BFR and how it applies to my rehabilitation practice. Let's see what's going on. Next week I'll be teaching in Colorado Springs. And I'm doing a public BFR course. What else is going on? The other thing you should know is that I always post these on my YouTube channel, which is just Ed Cara. And so these always go up there, so you can always review anything that I've discussed in the past. And yeah, that's about it. Anybody have any questions today before I get started? Questions regarding BFR or anything else? All right, so what I'm going to do is my plan today was to take kind of people through normal, kind of what my thought process is with when I have a new client and if I'm going to apply BFR to them or not. So let me share my screen and I'll get right with it. All right, so I'm sharing my screen here. So I'm just going to come to this point right here. So I'm going to start this off with first thing really that I'm going to do is look at the complaint. So what is the complaint? And most of the time in my clinic, it's pain, inability to perform activities. I do see some atrophy. What else? Okay, so pain. One can be true, like let's say acute injury. We'll call this one cumulative injury. I spelled that wrong. All right. So if pain is above 5 out of 10, I'm going to spend most of my time on reducing pain, inflammation, and improve range of motion. If is below 5 out of 10, I spend, let's say between 3 to 5 out of 10, I spend, let's say 1/4 time, let's say 1/4 to 1/2 time decreasing pain. And then I'll spend 1/4 to 1/2 and then this is, I mean, really, this could be a 30-minute session, or this could be an hour session. 1/4 to 1/2 amount of that time I'm going to spend on improving functional capacity. So first we got to think about what the contraindications. And I like to categorize these into 5 different segments. So the first segment is, is the individual more susceptible? Gosh, I can't spell today. Susceptible to thrombus. Really? Not even close. All right, that doesn't look right at all. Circumpital. God, that's all right. Is individual more at risk for thrombus formation? Second question that I ask is there any cardiovascular risk? And there's 2 different cardiovascular risks. There's central risk, and then there's peripheral risk. The central risk means I can't get their heart rate up too high, or I can't get their blood pressure up too high, meaning they have uncontrolled hypertension. Peripheral risk means that there's been some sort of compromise to their vessels, meaning they've just had vascular surgery. They've had trauma to their veins, something along those lines. Next one I want to think about is there muscle damage risk. And that would mean, are they going to work out in an hour? And if I get them so tired from BFR right now, they might be compromised during their workout. Or it might be, hey, they've got 3 days before they train again. And so it's okay if I push them a little harder and cause a little bit of a soreness. So I've got to always know kind of where that is and where their workouts are and where their training is and where their next competition is. Because if I don't want to cause muscle damage, I don't want to increase stress to the tissue, then I'm not going to take people to failure, and I'm not going to do things that are going to be a little bit more aggressive. All right, so thrombus risk, cardiovascular risk, muscle damage risk, tourniquet risk. What's tourniquet risk? If I put a tourniquet on somebody, are they at any increase in risk of the tissue underneath that getting more damaged? So by using a good cuff, what I believe is the best cuff in the industry right now, which is the Smart Cuff, I reduce all my tourniquet risk essentially. I mean, there's still some risk there, but I'm really reducing it because it's a wide cuff. I inflate it to that person's specific limb occlusion pressure. I reduce my risk quite a bit when it comes to tourniquet risk using an FDA listed cuff. And then we have the miscellaneous risk that we have to think about, which is excessive swelling, meaning more than 2 inches circumferentially, one joint versus another. I mean, like if the elbow is 2 inches circumferentially larger than my left one, my uninvolved one, then I'd probably spend most of my time getting rid of the swelling, and I'd be spending less time doing strengthening or hypertrophy training. What else? Pregnancy is a risk. That's kind of that. And then age, less than 15 years of age. So if I have any of those 5, and those 5 are kind of, these are all the 5. 1, 2, So if I have any of those things, then I'm going to take a step back and see if they have any contraindications to me treating them. If they don't have any of those contraindications, then I'm going to ask myself, is the injured joint tissue mobile? And that's greater than, I'm going to say 85% normal range of motion. If yes, strengthening protocol. If no, I'm either going to do a cellular swelling protocol, or I'm going to either do cell swell, or I'm going to do maybe just a aerobic capacity. It just depends. It depends how much time I have. It depends on a lot of things. But, if you have good range of motion, then, and their pain levels are pretty low, then why not strengthen them? I think strengthening is the big equalizer and what we need to be doing with most people that we're not currently doing. So why would I do cellular swelling if they're not mobile in that joint? Well, if I can't do normal ranges of motion. Now, there is a tweener in there. The strengthening protocol doesn't have to be full on, isotonic strengthening. It could be isometrics. It could be, and it could be just your isotonic, I'll just say. So you can do it either way. You can combine these things. So if I have a full hour, but I am really treating somebody's elbow, let's say, I might do an aerobic capacity first to maintain their aerobic function, and then just do isolated exercises afterwards. So you can mix and match. You don't have to just stick with one, nor do you have to stay with one. You can jump over as long as they've proved to you that they can tolerate what you're asking the tissue and the person to do. All right, so if they're mobile, yes or no. And then if they're mobile, the other thing I've got to ask them too is, can they lift 20 to 40% 1 rep max? If yes, then they're going to do the hypertrophy / strength protocol. Gosh. 30 reps, 15, 15, 15 for each exercise. 30-second rest between. At about 20%, 1 rep max to start. Oh, I should put, if no, isometrics would probably be in order, and that would be 1 to 2 minutes times 3 rounds with 30-second rest between, no deflation. Okay, so we can use isometrics when they can't quite lift that 20% 1 rep max. Like, so let's say they have full range of motion, they don't have excessive swelling, but they're not quite ready for 20% of their 1 rep max with BFR, then just do an isometric until they are ready. Okay, and then let's see if they can lift. if they can lift greater than 65% 1 rep max, they should be doing their normal training and supplementing any weak areas a couple times a week with BFR. Okay, so that's kind of my thought process as I go through. I think the things to really look for in the acute injury is, you're looking at excessive pain, greater than a 5. You're looking at excessive swelling. Cumulative injury, I guess you're kind of looking at the same. But really, when you really boil it down, you're only looking at a few protocols. You're looking at passive therapy, really just using cellular swelling protocols. You're using strength and hypertrophy protocol. You're using aerobic capacity protocol. And really, there's some nuances in between there, but that's really about it. There's not that much else in there. Now, there's some things that we do prior to tendon injury and prior to certain things, but for this kind of basic map, that is really what I'm thinking about when it comes to rehabbing somebody with BFR. Push them to the point where they can tolerate without pushing them over a cliff, which means increasing their pain or increasing their swelling. So I'm gonna, let me see if I can save this. Oh, maybe I can, let's see. I can screenshot it. All right, I'm gonna stop sharing. Okay, any questions kind of about that roadmap? If you do, then just put it into the comments section. I'm gonna share that guy. I'm gonna see if I can find it now. And I'll just shove it in there. Hopefully I can find it. That's usually the hardest part. Screenshot. Okay, it's uploading. So any questions regarding my kind of what I'm thinking as I'm going through this thought process on using BFR or not? I push them to the point where they can tolerate without causing increasing in pain and more than 20 or 30 minutes after exercise, because it's going to be a little uncomfortable. No increase in swelling. I'm always pushing to increase strength because ultimately I think that's what our job is getting people stronger and being able to tolerate more load, or demand, as I call it, which would then reduce injuries in the long run. Okay, hopefully that helps. Let me know if you have any questions, and hopefully that download helps. And that's about it for me. I was going to do ACL, but I thought I had done ACL, but it was 5 weeks ago. So if you want to look back at my YouTube channel, if you're not on it right now, but go on my YouTube channel, and I did one on ACL. There's a new study on ACL just about 5 weeks ago. So take a look at that replay if you are looking at ACL. I know there were some questions last week. All right, I got to get back to patient care. If you have any questions, please email me, ed@edlacara.com. Otherwise, I hope to see you at a live training. If you need certification, I can do that online. Just let me know. I have an online course. And also I'll be basically traveling the world teaching BFR in different countries and states for the next probably 24 months. So just let me know what I can do to help. Thank you, be well, and have a great week.